months. Wow, that's significant.
Hello, good morning. Sorry about the slightly late start. So my name again is Petronella Adomako, Infectious Disease Dr. Adomako. For this morning, we are going to have a panel discussion, going to present some cases to our esteemed panel over here, and we are going to discuss, give us differentials, we come up with a diagnosis. So I'd like to introduce you to our panel from right to left. We have Dr. Scott Fredrickson. He works with the Emergency Physicians Integrated Care, and if there are any of the providers from that group, would like for them to stand up, and we do appreciate their sponsorship for today. Thank you. And then we have Kory Anderson, Dr. Kory Anderson. He's a hospitalist associated with Intermountain, Makedi Hospital, Layton Hospital, and he's also a medical director for Physician Advisor Service and CDI. If there are any providers from Intermountain, would like for you to stand up. We do appreciate your sponsorship. Thank you. Then we have Dr. Tamara Todd. She is with Utah Emergency Physicians. She's an ED physician, and she's also Medical Director of Care Transformation and Information Services with Intermountain Healthcare. Again, if we have any providers associated with Utah Emergency Physicians, we do appreciate their sponsorship. Not sure if any of them would be here today, right? Thank you anyway.
I'm here.
And finally, we have Dr. Cook, Dr. Johnnie Cook. We all know him. He's with Tanner Clinic, family practice, and we do appreciate Tanner Clinic for sponsoring this section today. If they have any providers here from Tanner Clinic, if you could please stand up. Thank you. So we'll start off with the cases. Ooh. Can you enlarge the screen over here because I cannot see anything? On the other hand, I'll pull up my phone. Oh, there we go. Thank you. Now, the button is not responding. Good to go? Oh, shucks. I can't go back. Can you go back for me, please? Yeah, I pushed it, not responding. Man, I don't want it. Okay, whilst we're trying to sort that out, let me read the case. So, I got called by a patient of mine, a 43-year-old man with HIV, very well controlled. His viral load was undetectable. His CD4 count was 542. He stated that he had been having brown-colored urine of about a week's duration, not associated with any dysuria, urethral discharge. And he also had generalized myalgia of a month's duration. In addition to this, he had headaches with some visual disturbances. Now, he was in New York, and his insurance was not accepted in New York, so the decision was made for him to fly back to Utah and get some laboratory studies done, then he could be seen. So, the laboratory studies ordered were a CBC and a CMP. Basically, his baseline labs, because with all the HIV patients, I tend to get baseline labs of CBC, CMP. I also get their CD4 count, the frequency varies. I get their viral load as well as some STD tests as well. So when he came in, he had the blood work done, and these are the initial labs. His CBC was 12.1. His everything else was normal except for his CMP, which showed a total bilirubin of 4.4. His alkaline phosphatase was markedly elevated at 1186. His AST 316 and ALT of 445. You've already seen my third slide, but at this time I will just hand it over to the panelists to see whether what they think at this time and what they would like to do, or what other tests they would like to do, and what differentials they are considering. So who would like to take that? Ladies first, Dr. Todd.
Thank you so much. Awesome. I still would consider tertiary syphilis and tabes dorsalis with this presentation. So I would follow up on the RPR and then consult my fantastic ID colleagues.
Okay, I like that. Dr. Anderson?
I'm glad she went straight to the ID doc and didn't call the hospitalist first. And I can see why you said you wanted all the good hospitalists to stay at the hospital today, and that's why I'm here. So I think when I looked at this, I thought, one, we didn't have the lab results. Looking at this case, we just, I think, saw some of the labs that you'd ordered, but didn't know the results. A couple things that I was thinking about as I read through this case was, one, the patient's compliance with his medications. Obviously, that has a big role in whether there's other things that we should be considering or not, as that would likely dictate what his CD4 count would come back as. The other thing I thought about was, medication reactions, especially with the raw Tegravir, dark urine. Rhabdo is something I would be thinking about. Elevated liver function tests is associated with that. And then I think some of the secondary infections that we talked about, with the neurosymptoms, tertiary syphilis, toxo, things of that nature were some of the things that I started to think about as I looked through this based on his symptoms, not knowing what some of these lab results looked like. So.
Okay. Any other thoughts?
I think I would have called you before I would have called anybody else, yes.
Okay, so when he called me and told me brown urine, I was thinking some kind of hemolysis, some jaundice. So I ordered the CBC and the CMP. The other tests were just baseline tests that, like I said before, I order routinely. So it was, there we go, it was an incidental finding. So his RPR, which had been done about 3 or 6 months ago, was non-reactive. This was then resulted as 1 in 164. So he did follow up with me in clinic, and that's when he complained of the visual disturbances, the headache, and he also did mention having numbness radiating from the neck down. With the visual disturbances, I was thinking, and the headaches, I was thinking possibility of neurosyphilis. So the idea was, okay, let's go ahead and get a lumbar puncture, but the clinical suspicion was so high that the decision was made to go ahead and treat him for presumptive neurosyphilis. And this lumbar puncture, that's a cerebrospinal fluid analysis. His total protein was 86, as we can see, WBC of 16, RBC of 3. VDRL was negative, but it's not very sensitive. And again, based on his clinical presentation and the laboratory studies of RPR of 1 in 164, it was a presumptive diagnosis of neurosyphilis, despite the fact that the VDRL was negative. So any questions so far? How would you treat this patient? Neurosyphilis?
Penicillin.
Penicillin.
I'm sorry?
Penicillin.
Yeah, so that's what we did. Okay. Oh, it's moving. There we go again. Don't look. Don't look. Okay. So syphilis. We have different types of syphilis. We have the early syphilis, which is basically the skin lesion known as the chancre at the site of the inoculation. The incubation period ranges from 3 to 90 days and usually resolves within 3 to 6 weeks. We have then the secondary syphilis, which is characterized by constitutional symptoms of adenopathy and a rash. And then you can have the other end organ involvement where you have the gastrointestinal syphilis as well as hepatitis. In his case, if you can remember, his alkaline phosphatase was elevated quite high at 1186, and the AST and ALT were in the 3 to 400s. There can also be some renal involvement and neurosyphilis. And then we also know that there's late syphilis, which is cardiovascular syphilis, as well as tabes dorsalis and the gametous syphilis. Why am I not getting this right?
Petronella.
Yeah.
Just go slower.
Slower?
Yeah. There's a little bit of a delay.
Okay. Eyes closed?
Can I ask a question?
Yes.
Is there a different treatment modality for penicillin depending on the stages of syphilis?
Yes, so it was early syphilis, just one shot of benzathine penicillin IM. Latent syphilis, where you cannot determine how long the person has had it, is 3 shots of benzathine penicillin weekly, once a week for 3 weeks. And then with the neurosyphilis, we go with the intravenous treatment. Now, I must also mention that, back to the diagnosis, we know the diagnosis of syphilis. We have the non-treponemal test, which is the RPR and the VDRL. And then we have the treponemal one, which is the FTA antibodies, as well as a few others. I don't think a lot of people are doing the dark field microscopy at this time. Most of us are just going by RPR and the treponemal test. So the treatment is the benzathine penicillin, as I mentioned. For early syphilis, it's just 1 shot. For latent syphilis, secondary syphilis with no involvement of the CNS, you treat with benzathine penicillin weekly for 3 weeks. You can use doxycycline. There's also amoxicillin with probenecid and ceftriaxone. And with neurosyphilis, you have penicillin, intravenous penicillin, and ceftriaxone. In terms of monitoring, once you're done with treatment, you want to check their RPR serologic testing at 6, 12, and 24 months, respectively. So any questions on that? Okay. Am I not punching it in the right place?
There you are.
I think she's going backwards.
It's recording every click, but there's a delay after you click, so just click once and wait.
Okay. So we all know the diagnosis of the second case. I still want to know what their differentials are, though. So this is 50. Is it coming up? Okay, it's gone up. Did we restart it, or did I restart it?
I did, so see if that.
So case 2, this is a 58-year-old man who was referred to me in clinic with high-grade fevers, with a complaint of high-grade fevers associated with diarrhea and abdominal cramping. He had no localizing symptoms, at least when I saw him. He had been referred to me by his primary care provider, who had done extensive workup for the persistent fevers. So he had done blood cultures, he had done a CBC, CMP, imaging studies, and had also done some autoimmune workup, and nothing had been found. Patient felt slightly better, but not completely, not 100%, hence the reason for referral to me. So in terms of the history, what I've said, he had no localizing symptoms when he saw me. He was feeling slightly better, but nothing localizing. He still wasn't having the persistent fevers, but he had mentioned that he worked on a farm. He owns a farm, worked on the farm with livestock. He had been exposed to birthing animals. And so he did have, and his exam was completely within normal. He did have labs done, the CBC, just mild anemia, hemoglobin of 12.4, and his alkaline phosphatase, everything else was normal. His CMP showed an alkaline phosphatase of 180, AST of 100, and ALT of 141. I know I've already talked about the diagnosis, but I want to hear the differentials. So Dr. Fredrickson, any thoughts?
So you said he had been working with cattle, correct?
Yes.
And so I'm thinking more of zoonotic infections. And to be honest, I mean, that's not something we see very commonly. So when somebody has persistent fevers, common things being commonly, I would think, it sounds like his blood cultures were negative, but I would think about something like bacterial endocarditis, perhaps cancer with weight loss, tuberculosis. But it seems like a lot of that stuff had been evaluated, and then looking at more exotic, or at least in the emergency department, they're more exotic Q fever, brucellosis, chlamydiosis, and campylobacter would kind of be some of my other thoughts that I was able to
Okay.
investigate.
Any other thoughts from the panel?
Go ahead, John.
And it was interesting to learn a little bit about Q fever. That was kind of what came up just with the birthing and being around animals, and learn a little bit about the history of how that got named. Anyway,
Okay.
it's Australian if you want to know.
So Petronella, I think a couple of things that I was thinking, again, obviously I would want to know, was this bloody diarrhea, non-bloody diarrhea, just thinking of those common fever diarrhea things that we see oftentimes in the standard infectious causes that we see associated with that. Did he have any at-risk behavior? So was he, potentially an HIV patient, where again, we're thinking of some other things. But I, again, like Scott, went to the Google or whatever your, app or website of choice is, and what are the zoonoses associated with cattle, and listeria, Q fever, brucellosis, leptospirosis were the ones that kind of seem to come up as potential things to consider. But I also thought about like a post-infectious IBD type of syndrome, or malignancy, some of those other things that seem less likely based on the initial workup. But.
Yeah, so he had seen me about 2 to 3 months after his symptoms started. So I didn't think he had any of those acute ones like listeriosis. And I must admit I was a little bit biased here because I had been referred a patient who had hepatitis as well, had been seen by a gastroenterologist, and the gastroenterologist had ordered a liver biopsy, which showed findings that favored Q fever. So in light of that, I think that was my first diagnosis I went to. I figured let's test him for Q fever, that's Coxiella burnetii, and the serologies were what you saw.
Okay, so if you just tell me when you want to.
Awesome. So can we go to discussion for case 2? Yeah, so these are the Coxiella, the burnetii, the serologies that you can see, and you can see that they were extremely high. So this was a clear positive case. And I did prescribe doxycycline for the patient. He felt much better after his course of treatment. But his serologies have still remained high. And in talking to him, again, he has no significant localizing symptoms. And so we're still kind of monitoring to see how things go. So in terms of a little bit about Coxiella burnetii, so it's caused Q fever, also stands for query fever. First, I believe, as Dr. Cook said, in Australia, Queensland, Australia. It's caused by Coxiella burnetii. It's found in mammals, sheep, goat, cattle, and we know this individual was working with cattle exposed to birthing animals. And the main reservoir is ticks, so the ticks infect the mammals, and then humans acquire it through inhalation. But they could also get it through drinking raw milk or occasional blood transfusions. So what are the clinical manifestations? We do have acute Q fever where they can have flu-like illnesses. It's usually self-limited about 2 to 14 days, which probably happened in this patient. They can also have pneumonia with hepatitis, and they can also develop endocarditis. Then you can also have the chronic, persistent, or localized infection, which is characterized by endocarditis, osteomyelitis, or vascular infection. So if the patient's serologies are not decreased and you want to get an echocardiogram to make sure that this individual does not have endocarditis, you could also get a PET CT scan with FDG to see whether it would light up looking for osteomyelitis. And vascular infection, you would hope that something may come up from blood, but it's not something that we can culture easily. In terms of diagnosis, we are looking at the serology, so you're testing for serologies, and you can also get PCR on tissue samples. And the treatment is mainly the tetracycline, so you use doxycycline or minocycline. But Bactrim is also effective. The fluoroquinolones are also effective. And if the individual does have endocarditis, you're treating with doxycycline and hydroxychloroquine. So, any questions? None? Oh, we're moving too fast. Okay. So next case. So the next case is a 56-year-old man who presented to the emergency department with a complaint of a chronic cough of about 7 to 8 months duration. The cough was occasionally productive of greenish sputum. He did have some shortness of breath and chest pain and occasional pain in the left shoulder, but his symptoms were not severe, so he kind of dealt with it till about 3 weeks prior to presentation when the symptoms worsened, in light of which he presented to the emergency department. He did not have any fevers or night sweats or weight loss associated with the symptoms. And there was no history of exposure to anyone with a chronic cough. So he was evaluated in the emergency department and had a CT scan done of the chest, found to have an abscess in the right upper lobe. He was also found to have acute kidney injury, and in light of which he underwent a biopsy of the site and was eventually diagnosed with palsy immune ANCA vasculitis. He was discharged home on augmentin and immunosuppressive therapy for the vasculitis. So, what are your thoughts on this patient?
Woo.
So, Dr. Todd?
Yeah, no worries, got it. So if I saw this patient in my emergency department bouncing back, I would still assess for both common causes and then perhaps less common causes. So I would draw cultures again. This guy has a lung abscess that got worse with immunosuppression and antibiotics. So is this some sort of autoimmune process with a superimposed fungal infection? So I would redraw blood cultures. I'd draw fungal blood cultures. I would consult ID. I would Google and think maybe Wegener's, which is also known as granulomatosis polyangiitis, and also be really thinking about perhaps a superimposed fungal infection, still considered TB and things like that.
Okay, great. Because there was no history of exposure to TB, I don't believe he had AFBs done, but I think a quantiferon gold done was resulted as negative.
Okay.
Sputum cultures did not isolate any organisms, so this was just CT says abscess in the right upper lobe, so we just treat with antibiotics. Fungal serologies, negative.
Okay.
Yeah. So any other thoughts?
Well, so Petronella, probably, despite whatever I think, after I called Jeff Booth and asked him what was going on here, and then I called you and asked you what was going on here. A couple of other thoughts too, I think, is this his vasculitis that's uncontrolled? So I would probably be checking inflammatory markers to see if those are going up versus have they come down. Is there some utility in checking, the ANCA studies again to see if those are downtrending with response to therapy? What was his induction therapy? Did he take it? Was he compliant? Again, all the secondary infections that I think Tamara kind of talked about, I would be considering those sorts of things as well as potential possibilities.
Yeah, so he was he did take his medications. He was discharged home on prednisone. I think they also started cyclosporin. The reason why I got to see him in the hospital was they're going to start him on immunosuppressive therapy. And the concern was make sure it's not an infection before we start him on the immunosuppressive therapy. And based on his findings, his laboratory studies really did favor the immunosuppressive therapy. So I said, okay, let's do augmentin empirically, and let's just follow up on outpatient basis to assess for resolution of the lung lesion. So that's what we did. Next slide, please.
And he had Q fever too?
Another case.
I didn't consider that one on this.
Yeah, no, me
my
neither.
differential
Yeah.
factor.
Did I put the wrong slide? It is. Next slide. Next. Okay, so he did follow up with his rheumatologist, who discussed with me, and the decision was, patient was actually feeling better, but the decision was made, let's get a repeat CT scan to see whether he has some improvement. And the repeat CT scan done of the chest showed that the mass in the right upper lobe had slightly increased in size with a new area of cavitation, with increase in size of nodules in the interlobar fissures of the right lung. So again, what would you want to do at this time? Now you've ruled out the fungal serologies, you've ruled out tuberculosis, anything else?
I might send the patient for a VATS, not from the ER, but
Okay.
yeah, I'd think about a biopsy.
Yeah. So that's what was done. A biopsy was done, and patient was found to have squamous cell carcinoma of the lung. So next slide, please. Now this is not my specialty. there. So I spoke with the rheumatologist. Patient was diagnosed as having paraneoplastic vasculitis. So he really did have vasculitis, but this was believed to be associated with the malignancy. Could you please forward the slide?
So did they biopsy the same area as the abscess that they had, quote, aspirated? So it was the same location, just different result.
Right. So the biopsy, and that was the first biopsy we had. We hadn't gotten a biopsy previously. So just a little talk about paraneoplastic syndromes. We know that some rheumatological disorders can be associated with malignancies, and we see that with dermatomyositis and polymyositis, it can be associated with certain types of malignancies. Now I need my slide still off. Okay. Now that's not my specialty. I'm not a rheumatologist, but some of the differential diagnoses that we have to consider would be lupus, that can be SLE, can be associated with lymphoma. Rheumatoid arthritis can be associated with lymphoproliferative disorders. Sjogren's syndrome can be associated with the same, that's the lymphoproliferative disorders. And we can see systemic sclerosis also associated with solid tumors such as liver, lung, bladder, and tongue cancers. So, any questions? None? Okay, so the final case. I thought we were going to be moving slower than this, so I had only 4 cases. So the final case, you are approached by a patient other, OTHER, was recently diagnosed as having herpes simplex infection and genital herpes, and he or she would like to be tested. So the question is, would you test or not?
So for me, I'm not even sure. I know I test patients when we test their CSF. I don't know if we have a PCR test for blood in our hospital, so I'd have to first look into that. If they really wanted the test, I'd have to explain that there's some limitations to it, that you could get a positive even if they just have oral disease. But I'd kind of discuss it with them and see if they want to be tested, and then if I had the test, I may consider it. But I'd have to look up to see if we have the test.
Okay.
Yeah, it'd probably be a send out for sure.
Send out, okay.
Yeah.
Dr. Cook?
Because type 1 and type 2 aren't just oral and genital, and almost everybody has type 1, at least oral, it makes it, so you just have to explain the limitations to the patient.
Okay.
So I got to be honest, in 13 plus years as a hospitalist, I have never come across this clinical situation. That is usually not what we're addressing, and I probably consult one of the family practice residents for their opinion about what we should do. But what I read was essentially what these, the others said was that some counseling, probably tests, as it may be helpful in determining their risk of acquisition of the disease from their partner, and may also guide whether you want the partner to be on some sort of suppressive therapy kind of chronically to help in preventing transmission. So.
Yeah, the only thing I'd add is we're really trying to push more community STD testing in general in conjunction, not just with focused gonorrhea or chlamydia, but make sure you test for HIV, which has been a push from our ID leadership. So I might offer the patient full testing with HIV and gonorrhea and chlamydia just because it's good stewardship. If they're worried about herpes, they might be worried about other things as well.
So the reason why I bring this up, I was cited a number of years ago about a patient whose significant other tested positive. And the provider said she had tested the significant other, and that was resulted as positive, and they were looking at getting divorced. So then the question is, if you have someone who is asymptomatic, just wanted to get tested because the partner was positive, you would really have to counsel that individual to let them know the test available, the utility of testing, what is going to be done with the test. And they should bear in mind that one thing we always have to stress out is that do not take it that because your test came back positive, the significant other gave it to you. Because you could have acquired it a number of years ago. We just don't know when. It's just telling us that you've been tested. I mean, you're positive. And any other recommendations regarding counseling?
Marriage counseling?
I agree with that.
Yeah, they'll need barrier protection if they want to prevent, further spread. If otherwise, just kind of protection and treatment, or not treatment, but prevention of further STDs and that sort of stuff.
Okay, so in terms of testing that's available for herpes simplex, we do have serology testing that can differentiate between type 1 and type 2. But the type 1 and type 2 does not tell you whether it's genital herpes or oral herpes if the patient is positive, because each can cause either. I mean, granted, there's a propensity for one to be higher than the other, but each can be positive. So just the fact that they have a positive test for HSV1 or HSV2 does not necessarily mean that they are prone to genital herpes or oral herpes. Now, we do not recommend testing for IgM because I've noticed, well, I shouldn't say I have noticed because we should go by the data. Some of the herpes viridae, when you test the IgM, they tend to be positive even though the IgG is positive. And we can see a positive IgM with immune dysfunction. So sometimes you can have patients who come in with a herpes HSV1, HSV IgM positive, HSV IgG2, IgG positive. It does not mean that it's an acute infection or a recent infection. It basically doesn't tell us much. All we know is that the individual has herpes simplex, especially if the IgG is positive. We also see cases where you have the EBV, multiple EBV serologies being positive, and the question then becomes, does the patient have chronic EBV infection? No, the person does not have chronic EBV infection. I'm just kind of talking about all herpes viridae in general. The individual does not have chronic EBV infection, especially if the IgG is positive. Again, it's related to some kind of immune dysfunction that can make some of the IgM result as positive, even though that's not really an acute infection. So if you're suspecting an acute infection with herpes simplex, the best thing to get is a PCR test. And the PCR test, next slide please. And the PCR test can be done on the tissue. So if the individual comes with vesicles, you can get a biopsy and do a PCR test on that. If you're suspecting herpes simplex encephalitis, you do a PCR on the CSF. Occasionally, too, you can get a herpes PCR on blood. And when it's on blood, the assumption is that it's possible that the individual has disseminated herpes simplex infection. You can also do a viral culture, but now that we have PCR, it's much easier to just go ahead and do the PCR study instead of the culture, because your turnaround time is much faster. And then you can do the direct fluorescent antibody assay. I think the family practice providers probably do that more than I do, where you can you do a swab or a biopsy and then do a direct antibody staining against that. And they can also do the tongue smear, which is something I have read about but I've never done. So I just go with the PCR studies. So as mentioned before, the serologic test, you can just differentiate between HSV1 and HSV2. You can have false negative and false positives as well. Now, it's just helpful in certain scenarios. So as Dr. Anderson mentioned, if you want to test the significant other, if it comes back positive, it does not mean your partner necessarily gave it to you. You could have gotten it years before. If it comes back negative, then you can take the necessary precautions. So where you have talk about the barrier methods. If you're dealing with, and if it's positive in an individual who has recurrent genital herpes, then there's the role for suppressive antiviral therapy, where they've had at least 3 or 6 episodes per year, or breakouts of genital herpes per year. You can give them suppressive therapy with valacyclovir. And then in individuals who are immunosuppressed, such as transplant patients or individuals on chemotherapy, you may consider giving them testing, and if that comes back positive, you may consider giving them prophylaxis. Yes, sir.
What if this patient was 36 weeks pregnant? Yes. Would you do
it's active.
If the patient had it, if they have active lesions, then probably I would leave that to the obstetrics and gynecologists whether they want to do a C-section. But if they have no active lesions and it's just a positive serology, there's no need to do anything. Just a spontaneous vaginal delivery should be fine. Because that's all it's telling us, that you've been exposed in the past, but it doesn't tell us anything else. Yes, ma'am.
So what I didn't hear was the partner's testing, the original testing. So you want to know that, you want to know why this person wants testing, and then we've got prognosis that comes from knowing whether it's type 1 or type 2, as I understand it. The American Sexual Health Association website is an awesome go-to for the patient, and their real-time feedback and chats with physicians on staff there.
Right, so that's again, the issue is, you're right. The partner, if the partner is positive, we know the partner is positive, and they came to us because the partner is positive and they want to know their status. I tell them that yes, you can get tested, but again, it's not going to make any difference because this thing is dormant in the body. We can never get rid of it. We cannot cure you of it. We can only test you if you have a breakout where you have, treat you if you have encephalitis, but we cannot cure you. So you can test if you want, but it's not going to make any difference in our management. Any other questions? Sorry, I finished so early. So those are the cases I had. There was a fifth case, but I don't have the data there.
That's good. That was the hardest one.
So I'll just throw this out there if you can remember. So this was a young man, I believe in his 20s, who sometime in September last year, he had been feeling generally unwell. He had been having, I think he had first presented with nausea, vomiting, abdominal pain, had presented to the emergency department. They did imaging studies eventually and found that he had these shorty lymph nodes that you could find in the inguinal area. But somehow he was lost to follow-up and didn't show up again till sometime this year, where, again, because he had another CT scan which showed the shorty lymph nodes. He had had an ANA done, which was apparently resulted as negative. And so because of the shorty lymph nodes with constitutional symptoms, he was referred to an oncologist. So with that in mind, what would you do?
Go ahead, Dan.
I can chat for a bit. So just in thinking about possibilities, you think about infectious things. This is an infectious disease conference. So Epstein-Barr virus would want to know his monostatus. And then malignancies is another possibility. Those would be the first things I would think of. Autoimmune, you mentioned negative ANA, but rarely can still be a cause.
Okay.
So I think when you gave us the case, a couple of the things that you had included in there was the patient had autoimmune hemolytic anemia that was
Right.
cold agglutinin positive. So that obviously triggers some thoughts, and then came back with arthralgias and pain in the arms with hyperesthesia.
Right.
So, my thought initially thinking of this, again, cold agglutinin, autoimmune hemolytic anemia is things like lymphoma with the lymphadenopathy, mycoplasma infection, EBV, and then other sorts of viral sort of sequelae. There are other, rheumatological things to consider, I think, as well. Lupus, that's always in every differential that every doctor comes up with. But my other question was with the bacteremia. I didn't know if that was directly related to the underlying cause or a sequelae of something else. And did this patient now have a epidural abscess, for example? Some kind of transverse myelitis that was tied into whatever was triggering all the lymphadenopathy, those are the things I was thinking of, but I don't know, I'll be anxiously awaiting to hear what they have.
So he did see the oncologist, and the oncologist referred him to the general surgeon, and patient underwent a biopsy of the inguinal lymph node. Then a few weeks later, he presented to the emergency department with fevers and had blood cultures taken. And blood cultures isolated methicillin-sensitive Staphylococcus aureus. So the patient was admitted to the hospital for further workup. So whenever anyone has methicillin-sensitive Staphylococcus aureus, because of the tendency of that organism to cause endocarditis and musculoskeletal infections, extensive workup had been done. He had a transthoracic echocardiogram. He had a transesophageal echocardiogram. He had our newest test on the block, that's PET-CT scan, with FDG, and there was no clear source of infection identified except for the FDG lighting up in the inguinal area. And he still was not clinically improving, and because of the history of the autoimmune hemolytic anemia and generalized arthralgia, rheumatology consult was sought. And he did have an ANA test done again, and this time it was resulted as positive. In addition to that, I forgot to mention, he did have proteinuria with some hematuria. So he had a biopsy done. So even though he was doing well clinically, laboratory studies looked fine in terms of kidney function. The biopsy showed stage 4 kidney disease from the lupus. So we treated him for the bacteremia, and then he was started on prednisone, and I believe cyclosporin as well for the management of the renal involvement of the lupus. So it appears that his main problem was the lupus. The bacteremia was just a superimposed infection that he had secondary to the procedure that he had had. So those are the cases that we have. Any questions? None? So I guess we get out 15 minutes earlier. The next lecture is going to be here at 11 o'clock. So I guess you can get a 15-minute break and come back in time for the next lecture. And thank you very much to our panel. Really
Thank you,
appreciate it.
Petronella.
Throw lupus in there enough times, eventually you'll catch one, right?
Lupus, lupus, and lupus.